Greetings and welcome to this video on antibiotic series. Here we discuss about vancomycin, especially the intravenous formulation that we give vancomycin, especially for MRSA infections. In this video, we'll discuss about the mechanisms, spectrum of activity, toxicity, and dosing guidelines for vancomycin. So this is a very complex structure of the vancomycin and why it is so complex and how it acts. We'll discuss it in detail. If you're new to this channel, do subscribe. We'll discuss more about this antibiotic series. If you have not watched that playlist, go and watch that playlist. We'll give the link in the description. Let's get started. So, big picture, it's a glycopeptide for resistant gram positive. It's mainly used for resistant gram positive infections. Cornerstone therapy for MRSA empirical coverage. It is always, it can be given orally. The oral treatment is only for Clostridium difficile infection, that too for resistant Clostridium difficile infection. And you cannot give IV therapy for Clostridium difficile infection. So, IV does not treat Clostridium difficile. It is nephrotoxicity, so its usage is very limited. So, monitoring is very, very essential. The main stewardship in giving vancomycin is to protect the kidneys. So this is the take-home slides, take-home messages that you need to know about vancomycin. Mechanism of action, as you all know, it binds to DLR subunit and the terminal of the cell membrane, inhibits the peptidoglycan polymerization, and it is a bactericidal drug, but it is a very slow and time-dependent killing, not like the typical beta-lactam drugs that has a very fast time-dependent killing. So it is a very slow, but it is a bactericidal drug. And a very poor membrane penetration is there, and also very poor intracellular penetration. So this limits its usage in lung and CSF. Contraindications: severe dermatological reactions with Steven-Johnson toxic abdominal necrolysis stress syndrome, and the red man syndrome, which is usually not a true IgE allergy mediated. It is due to faster administration of the vancomycin drug that leads to this allergy or release of histamines, leading to this red person syndrome, or red man syndrome. So management for this is go for a slower distribution strategy over 1 to 2 hours to avoid this red man syndrome. And you can give antihistamines. The proof anaphylaxis can occur with vancomycin, but it is very, very rare. Drug-drug interaction is almost none. So pharmacodynamic interactions increase nephrotoxicity. With other nephrotoxins such as Victas, NSAIDs, contrast media, don't give it. It has its oral toxicity risk and do not give it with aminoglycosides or furosemide. Major adverse effect is again nephrotoxicity, the primary concern, and the dose and duration dependent, so hence not preferred. Oral toxicity is rare but usually reversible, and the red person syndrome or red man syndrome. So serious immune-mediated toxicities can occur in very rare cases. In prolonged usage, there can be neutropenia or ITP and stress syndrome, true allergic rash, and epidermal peeling can occur with prolonged dosages and immune-mediated toxicities. So spectrum is predominantly used nowadays for MRSA infections and the streptococci, including penicillin-resistant strains, Enterococcus fecalis, which is usually sensitive. So MSSA, don't go for a vancomycin drug. Or usually the beta-lactams are sensitive. If not, then you go for cefazolin, procloxacillin, dicloxacillin. These are the better drugs for MSSA and not vancomycin. And not for vancomycin-resistant Enterobacteriaceae. So for MIC, if it's less than 1, it is acceptable. For MIC 1.5, it is intermediate. And try to avoid if possible. If my MIC is more than 2, minimum inhibitory concentration is more than 2, it is resistant. So don't go for this. Clinical uses as of now is for empiric MRSA coverage mainly and for meningitis. So bacteremia, endocarditis, pneumonia, skin and soft tissue infection, surgical site infection, these are used. So stewardship rule is that you have to remember that you have to de-escalate within 48 hours if MRSA is not proven. So yeah, it's an excellent option in chronic dialysis. You can go for 1 dose of vancomycin before dialysis to prevent catheter site infection or contacting skin and soft tissue infections due to chronic dialysis. Dosing, it's for critical illness, is based on the adjusted body weight. If you have not watched the video on antibiotic basic approach, please do watch that. We have discussed in detail about the adjusted body weight and its calculation. So maximum is 300 milligram loading dose. It is 25 milligram per kg usually to attain the Cmax or the minimum inventory concentration. Then you have to dose it adequately to maintain the levels more than the minimum inventory concentration. So maintenance dose, if GFR is more than 70, given Q12th hourly. In case of augmented renal clearance, it is given Q8th hourly. If you do not know the concept of augmented renal clearance, do check out the video on basic antibiotic approach. We have discussed that in detail. So when GFR is less than 70, once daily dosing. If GFR is less than 30, or twice, once in 2 days dosing. And the GFR is less than 20, check the levels and the trough levels, and then go for dosing accordingly. So legacy troughs, previously skin and soft tissue infections, it was 10 to 15 micrograms per ml. For severe infections, 15 to 20 micrograms per ml. Less than 10 is leading to resistance risk. So this is the truck. This is the peak concentration attained after the loading dose. So after loading dose, there should be a truck level. Then again, you give another dose too, and again the dose increases and the concentration increases and again comes down. So the main target is to maintain the truck level above the minimum inventory concentration. So now the terminologies and guidelines have changed. Now it's more towards the area under the curve mechanism. So for area under the curve, this should be in the greater level. The more the area under the curve, both in minimum inventory concentration, more is the activity of the drug. And maintain the drug level with a constant range of around 10 to 15 micrograms per ml. For severe, it is 15 to 20 micrograms per ml. Constant monitoring is required when you give a vancomycin drug. So just don't give it blindly without monitoring the GFR and the drug levels. So special population in case of renal replacement therapy, the loading dose is unchanged. Intermittent hemodialysis, then 10 milligram per kg during the last hour. Avoid post-dialysis levels because of rebound levels. In continuous renal replacement therapy, loading dose is unchanged. Then the dose is 7.5 to 10 milligram per kg. Q12 hourly. Monitor closely. Obesity, you can maximum load it with 3 grams and up to 4.5 grams per day. ECMO is again similar dosing, it needs meticulous monitoring of the trough levels. Breakaway recovery, try to avoid vancomycin, consider linezolid or daptomycin, which are not nephrotoxic. Key stacks, it's a very highly hydrophilic molecule with a molecular weight of 1485 grams per mole. 50% it is protein bound with a very low volume of distribution of 0.7 liters per kg. It's mainly eliminated through the kidneys with 75 to 90% elimination through kidneys. Again, it has a very poor tissue penetration, especially the lung, poor CSF penetration, and half-life of around 4 to 8 hours, highly renal dependent. So there are two guidelines. IDSA currently recommends the area under the curve guidelines standard. We know truck guidelines which are previously used are nowadays not used because of the increased acute kidney injury risk and poor predictors of exposure. So the target was previously 15 to 20 milligram per liter. It was severe. Now it is changed to the area under the curve or MIC, that is 400 to 700. These are the current recommended standard guidelines that is used. So use area under the curve guided whenever feasible to protect the kidneys if MIC is more than 1.5 and always avoid vancomycin. So vancomycin is effective, but it's a very unforgiving drug. It is a highly nephrotoxic, CSF toxicity, and red band syndrome. All these are very toxic results of vancomycin, and need for the constant monitoring is very important. So load early, load increase in sepsis because of low volume of distribution, and monitor waste area under the curve overdraft if available. Stop early. So this is the take home point of this presentation. If you've gone through this, always de-escalate vancomycin if MRSA is excluded. So hope you will learned something about vancomycin and be confident in dosing. The usual dosing is 1 gram Q12 hourly in a normal 70 to 80 kg male patient. These are taken from the standard guidelines from IDSA, Sanford, and up to date. If you're new to this channel, do subscribe. We'll go through more of the antibiotic series and other topics which are beyond the Harrison's. If you are new to this channel, do subscribe. Thank you for watching.